Welcome to Cobb and Company, the regular podcast of the Montague Cobb Institute. I'm Rolf Taylor, producer and member of the hosting team, and I'm joined today by my co-host, Cobb Institute President and CEO, Dr. Randall Morgan.
Good morning, Rolf, and thank you. It is a pleasure for me to introduce our speaker, Dr. Maisha Standifer, who I have known for a considerable period of time in multiple roles when she was an early career scientist and researcher, as she has ascended to her current position as Director of Population Health with the Satcher Health Leadership Institute at Morehouse School of Medicine, and throughout that time also being a leader in an organization that we call the Cobb Scholars Program. Not only a leader, but a model, a mentor, and a recruiter for the Cobb Scholars Program. So that's sort of a 360 relationship with the Cobb Institute. And I'm so pleased to be a part of this discussion today with Dr. Standifer, Rolf.
Great to have you back, Dr. Standifer. And in our last conversation, you shared with us your perspective on medical anthropology, your time as a Cobb Scholar, and the importance of mentorship. So today, we'll take a closer look at the Satcher Health Leadership Institute's program that is tackling the structural barriers in HIV care impacting Black communities in the southern United States. And specifically, this program will focus on people living with HIV in Atlanta, Georgia, New Orleans, Baton Rouge, Louisiana. And as part of this initiative, Dr. Standifer, you're working at the forefront of addressing structural barriers that exist within those southern Black communities mentioned regarding things like HIV tests, regarding treatment, and ongoing care. So I'll hand over to Dr. Morgan. He's got lots of questions for you about the program and about the Satcher Institute, and look forward to learning more about this important program.
Thank you, Rolf. I am quite familiar with the Satcher Health Leadership Institute. It actually has been in existence about the same time that the Montague Cobb Health Research Institute has been in existence. And certainly my colleague and mentor, Dr. David Satcher, who is the founder of the Institute, helped us immensely when we began the Cobb Institute and still is one of our senior fellows and all-time role models. That being said, Dr. Standifer, I know you've been with the Institute for some time now.
Yeah.
How do you see the Institute's role today? Has it changed at all? And I think that can help us to understand perhaps the impact with regard to HIV.
Yes. So thank you again, Dr. Morgan and Ralph, for allowing me to come and just to amplify the mission of not just Morehouse School of Medicine, being a transformative institution focusing on advancing health equity, but also the Satcher Health Leadership Institute. As you talk about the change and what has evolved and why are we positioned in this particular time to highlight efforts in terms of advancing health equity and HIV. The HIV continuum especially. And so what, of course, talked earlier about the Satcher Health Leadership Institute and the development of it by Dr. Satcher being a leadership development training institute to continue to develop future medical professionals and public health leaders. And so what does that mean? That means, again, developing those skill sets that are naturally in the community, naturally embedded in the structural framework within the U.S. in the public health and medical system. So we're talking about educating, of course, medical school students, particularly here at Morehouse School of Medicine. We have PA students and MPH students, along with those who are also training to be and to go into a clinical setting. So we have with Morehouse Healthcare, we have residence programs here, and then we also have a clinical programming here. And so it's just a great opportunity that I'll highlight later in terms of how we're aligning some of those particular programs and establish training opportunities in terms of advancing HIV education and extending beyond stigma related kind of structures within the Black community. So what SHLI does is that we are bringing in of course, it's linking the anthropological efforts, being that anthropology, particularly the focus that I concentrated on, medical anthropology, looks at the intersections of illness, wellness along with sickness. And how do we kind of combine being an interdisciplinary and multidisciplinary, multisectorial kind of a cohort to making sure that we bring in all disciplines, all sectors to help alleviate any type of a negative or detrimental health outcome. And that happens to be right now the HIV epidemic that is increasing, particularly in the U.S. South, in Black communities, and those prioritized populations.
So did we have a period of time, Dr. Standifer, in which there was maybe a pause in the progression of HIV? Is the character of the disease changing, or is it all related to the environmental influences?
Well, a number of start to talk about, yes, related to a variety of environmental, political, right, influences as well. And
Sure.
So as we talk about that, again, aligning, just making sure I highlight what Satcher Health Leadership Institute does is that we're linking policy along with health equity. And that is a key component of what we do at the Satcher Health Leadership Institute. So as you talk about what is occurring, what has occurred with the history of HIV and AIDS, we know that it's at least 40 years ago. We can say 40 years ago in terms of the presence of HIV and AIDS taking the scene in the 1980s in the public health world, along with the medical and clinical treatments related to AIDS and HIV. And so we know that over the years, those decades, 4 decades, that we have been submerged in what's occurring, the transmission routes, right? And also education. And so we know that with education, Dr. Morgan, things have changed, right? When you're targeting at testing, where should we go to promote testing, promote education? That's where we went. And so when we first identified, well, what is HIV? What is AIDS? How does it progress? HIV going into, AIDS. How does that happen? And so we need to figure out, where do we go to find out what populations we need to concentrate on. And so when we went to same gender loving populations, that was a way of educating what's happening, talking about prevention, using protection to definitely decrease some of the new cases that were being seen. Again, that was 40 years ago. We also wanted to highlight the stigma that was around HIV and AIDS. So we know that it was often considered a death sentence when you were diagnosed with AIDS or HIV. That is no longer the case. So it has changed over the course of the decades that we've heard about it and HIV and AIDS, and that it has come in terms of entrenched into the public health community. And so when we talk about that, though, we have to have a caveat in terms of what it used to be and what it is now, particularly as we talk about education. So we talk about normalizing sexual health. That has often changed, right, over the years. Sexual health and accountability of oneself and what we need to do in terms of talking about sexual health in the community, in the society at large. That has changed. The stigma around sexuality, the stigma around being diagnosed with a sexual transmitted infection, making sure that we're saying, hey, take it upon oneself to be protected, whether you're using prophylaxis or you want to make sure you abstain. But we know that we really need to get into the crux of what's happening and being very culturally competent and culturally responsive. So over the years, yes, you said there was a pause. There was a decrease, right? In the cases, the number of new cases. But what we have recently seen, we all have been impacted by a public health pandemic that was about over 4 years ago, and that was COVID-19. And COVID-19 was able to pull back the scab, as many people talk about this in public health and in the medical field, of what is really occurring in healthcare systems and those vulnerable communities. And what we saw is a disruption of treatment for HIV. When we saw the disruption of treatment, we saw the disruption and the paradigm shift of what is relevant and who is being treated within certain populations. We saw that there was an increase in HIV diagnosis. So what did that say? Of course, as you talk about, Dr. Morgan, environmental, psychological, emotional, and physical changes, right? And so we saw that with, number one, the disruption in care, hospitals, clinics that were servicing prioritized populations were closed. Hours were amended, right? And those were those of the individuals who were not able to kind of continue with services, whether they be impacted by social determinants of health, not having insurance, accessibility, again, to cover either new diagnosis treatments or continuing on with regimen if you were diagnosed with HIV. And so we saw that, okay, there was a disruption, particularly also in those who were already displaced and marginalized, for those that did not have employment. Of course, we talk about if you did not have employment, you did not have coverage for insurance to continue your medicine. So again, we talk about those systematic and systemic barriers that impacted those who were diagnosed, and also because of the pandemic. And so we're aligning ourselves with Gilead Sciences, who found it natural to just, say, hey, what's happening? And we need to really go to some of these sources that are trusted in the community. And that would be historically Black colleges and universities and those historically Black institutions that have medical colleges and medical institution training the next generation. So we found it, just again, as we talked about, we would be remiss if we didn't align ourselves with some of those prominent institutions. Of course, here at Morehouse School of Medicine, we said, yes, we're able to continue and develop some natural, low-hanging fruit programs and initiatives, but also let's align ourselves, as we're talking about the Southeast being one of the highest and fastest growing regions to have new diagnoses of HIV. Let's align ourselves with other historically Black institutions. And that's where we're aligning ourselves with Xavier University of Louisiana and their College of Pharmacy. And it has been a great and very rewarding opportunity because both institutions are training future healthcare workers, Xavier training the future pharmacist in the space of HIV, where there has been a course created of HIV in the Black community in terms of what's happening in New Orleans, Baton Rouge, and Louisiana. Along that lines, we're talking about what's happening here at Morehouse School of Medicine. And as we continue to train the future generation of medical leaders and practitioners, why not have a course or curriculum and modules developed to educate those particular students, residents, and providers in this space in Atlanta and throughout the rural communities in Georgia, because we know from data, we also had to bring in our health equity tracker with HIV and say, hey, what is happening? Can you please provide information and data to say what's occurring. And that is, again, how we highlight what we need to do in terms of examining what's occurring, some of those structural barriers, dismantling those structural barriers, dismantling stigma, and really normalize, as I talk about sexuality and the discussion around HIV, whether it be in the clinical space or whether it be in the community-based organizations or those spaces in urban and rural America. And so as we talk about that, we know that in Southern Black communities, we're really going to amplify, and we really have been amplifying HIV testing. Again, knowing your status, knowing that there's treatment if you are diagnosed. There's excellent treatment that's there. You can survive and thrive with HIV, ongoing care, again, bringing in psychologists, and also highlighting other populations that really haven't been prioritized in our current settings, along with our Georgia Thrives campaign. And please go to georgiathrives.org. We're aiming to address the needs of Black communities in urban and rural Georgia, and that particularly lack accessibility to high quality education and treatment options.
How do you think the southeastern part of the United States has become such prominent location with regard to HIV/AIDS? I remember during the early days, the 80s and the 90s, of course, the large population communities, New York, Chicago, LA, Philly, where you had large populations in the urban communities, were always highlighted. There seemed to be the clinics, the activities. I didn't live in the South at that time, so I'm not really aware of what was going on in terms of prevention, diagnosis, and prevention. Has the character of the disease changed, or is it just the population shift that's made a difference?
All of that in terms of the characteristics of education, of what, as I talk about, COVID-19 has pulled back, unveiled what has already been there. And I think just in terms of, indeed, Dr. Morgan, amplifying what has already been there, right? What's happening. And so as we talk about some historical factors related to what HIV and the AIDS epidemic was 40 years ago, we just thought it was a gay male disease, right? You're familiar with that, and many in those clinical spaces that were there at that time. But we did not talk about those communities of color, right? Because we saw it most prevalent at that time. What was being pushed and visualized was a gay white male disease. Now, what has shifted in terms of being visualized over the time is that same gender loving Black men now have the highest incidence. We call that new cases of what is occurring with HIV. We know that Black males living in Georgia are over 6 times more likely to be diagnosed with HIV compared to white males. And as you talk about now, the shift, what has happened, we now have unveiled what has also steadily been growing, but now it's unveiled with provision of data and the promotion of health equity and health inequities. We understand that Black females, particularly in Georgia, are close to 12 times more likely to be diagnosed with HIV in comparison to white females. So the shift of visualizing and understanding what's occurring structurally, what's occurring socially is key. And that is what we're doing right now, Dr. Morgan. We're going into the communities of Black women and sitting down when we're seeing this increase and we're saying, what's happening? Can we really have an open, real dialogue on Black women who have families and may be diagnosed when they go in and they're pregnant, to be diagnosed and say, hey, what's going on with pregnancy? And they're diagnosed with not just, again, the pregnancy, but also being diagnosed with HIV and having other small children and so-called, thought being in a monogamous relationship. right? So this has changed, Dr. Morgan, from what we saw 40 years ago to what we're seeing now, when Black women are 12 times more likely to be diagnosed in Georgia with HIV compared to white women. What is occurring? What's happening? And so we're unveiling, as I talk about, continue to pull back the layers, sitting back with Black women, understanding what's happening with young Black women in settings where we're going on college campuses, we're going in community centers, we're going into clinics. We are, definitely informing OBGYNs, psychologists to understand, hey, let's talk with Black women and understand, what do we need to do? How do we need to educate and communicate with Black women? What do we need to do in the prioritized populations that we know may be more closely, linked to some of the transmission increases with HIV, maybe Black males who are same gender loving? What do we need to connect? This is 40 years in the making and understanding. Okay, we know that, condom use was very promoted, right? We understand, 90s, hey, utilize a condom. Let's protect yourself. But now when we go into these spaces, particularly in the young population, and individuals say, hey, I don't want to use a condom. I don't like it. I'm not going to use it at all. So we're understanding, there's a different mindset now, right? Okay, we need to really understand why and what do we need to do to circumvent some of the new cases. And so that's why we are, and also the pharmaceutical companies understand that, okay, then what do we need to do to really look at not just the HIV care continuum, but prevention? And so we're looking at PrEP, which is, yes. And so that's what we'll talk a little bit more about that, the promotion of PrEP and being a prevention mechanism and understanding, we need to arm individuals and who are in prioritized populations, as I highlight, Black women in Georgia and same gender loving men, and say, hey, then take some medication that can assist in terms of preventing HIV if you don't use, a condom of some sort. And so really understanding what's happening in the South, because it is rapidly growing in an increase of those who are living in the Southern United States. Again, we're not just talking about Georgia and Louisiana, but the Southern United States has the highest growing population in terms of new cases along Georgia, Florida, the Carolinas, Alabama, and Mississippi. And it's not just a coincidence, Dr. Morgan. You understand that the Southeast of the United States often, and we can talk about coverage, care for those who don't have healthcare insurance, is not being promoted in policy spaces as well. So it's not a coincidence. This is naturally going to happen. Naturally, those southern states are already kind of low in terms of the state of well-being in health in general, but also particularly in Black health. And we're not just talking about HIV, I'd like to highlight. We're talking along the health disparities umbrella. So we're talking about HIV and cancer. We're talking about diabetes, right? We're talking about any other heart diseases or conditions. So it is not a coincidence that some of the structural racist policies have been implemented, but we're talking about all of those things related to equitable treatment options. And so we need to understand that we are no longer operating in silos when we're talking about health inequities, but we need to make sure we're expansive in talking about coverage for individuals. And it's not just about healthcare. We're talking about housing. We're talking about employment, right? And we're talking about those educational needs. We know that the increase in education, you're more likely to possibly, get a job that has access to health insurance, to have access to clinicians who are well informed about the care that you need. And that is what we do. It's a we call it multi-tiered focus that what we're doing in terms of promoting data equity. So let's collect data from Black women. Let's collect data from same gender loving populations. Let's collect data from rural populations. Let's go and speak and create programs with rural clinicians who have an increase of those being diagnosed with HIV in their communities throughout Southern and West Georgia, but individuals don't have access, don't have transportation, don't have clinics to service them. So many are coming to Atlanta 2 or 3 hours to travel to get their treatment and then trying to, get access back. Again, talking about housing. We are connecting with programs that are there. So we know that we can't just focus on healthcare and health access and treatment, but we have to focus on that holistic perspective. So we're excited that we're able to do that.
Well, you should be excited.
Yes.
You will certainly have something to do every day.
Yes.
Because the problem is growing every day, or this set of problems is growing every day. Before we move on, are there any differences between what's going on in Georgia and what's going on in Louisiana that have caused you to align with Xavier and with Baton Rouge or Shreveport or wherever? Why that alliance?
Well, we talk about the alliance with HBCU. So there are many efforts now. We're excited that not only the federal government has recognized the need to include historically Black institutions in efforts to help decrease health disparities, but also private companies, particularly pharmaceutical companies. So Gilead Sciences knew that, okay, these are natural hanging alliances and networks that are there, that are trusted. Dr. Morgan, you have to have that trust factor there, right? You have to understand those spaces that are often seen as oppressed individuals and populations and institutions that have been in these communities for decades. They're there, natural locations and spaces where those in the community are trustworthy of the advice and the education that comes from there. So naturally, we're talking about Morehouse School of Medicine and Morehouse Healthcare. Again, and aligning ourselves with the other HBCUs. There are other efforts outside of ours. Of course, we're talking about Meharry and Howard they have funding from Gilead as well to really amplify what's happening and how do we connect the dots, right? So there are programs aligning them along with Drew in Los Angeles. But we also found it great to align with a pharmacy educational institution. So the pharmacy program at Xavier University was, again, a natural setting to look at MDs and training up the future clinicians at Morehouse School of Medicine, and then connecting those alignments and synergies that we have and the College of Pharmacy at Xavier. When we talk about the differences, what's happening, okay, that's a difference in terms of training, looking at pharmacy programs and pharmacy students to train, because they are going out into the community that's, naturally going to say, hey, we're here, can we get PrEP? How do we educate those pharmacists to naturally prescribe PrEP when individuals come into the pharmacies? How do we do that also in Georgia? So we thought, okay, that's great. But then we have great alignment as well as I talk about synergies. We know that the increase in HIV diagnosis is also in those Black populations, those prioritized populations, the same gender-loving individuals, also with Black women in Louisiana. The difference is that, Louisiana has parishes, right? We have counties, but also looking at some of the, it's not just New Orleans, but we're going into some Baton Rouge, and we're going into some of the, we call them, rural here, but also some of those remote areas that don't have a visibility, but still have marginalized populations that are being diagnosed. So we found differences that are there, but making sure that we align with those differences and those synergies, bringing everything together. So as we talk about what we're both doing, is that we are both prioritizing policy efforts. And so it's great what Xavier is doing, is that they have been involved with the commission to educate policymakers on assisting and informing policymakers on the advantages of providing HIV care and treatment, particularly through the lens of pharmacy care And so they have been very advantageous and in terms of promoting and actually getting some legislation passed to have pharmacists. And those are so in those natural settings, as we talk about, those rural parishes, to get pharmacists to prescribe PrEP and to prescribe, not necessarily going into a clinic or a doctor's office, but going to your local pharmacist in Louisiana. That's a big advantage of that, creating and eliminating some barriers that were there for those who don't have access or even the availability to go and have insurance coverage. But now individuals can go straight to their local pharmacy to request PrEP, right? And that is what we intend to do at Morehouse School of Medicine. Xavier also has created a course for the next generation of pharmacists that they're training on HIV and the Black community, knowing the importance of training those who are under 30, who are going to service those under 30. So found it very, very advantageous to make sure we align with another institution that focuses on servicing the most vulnerable, particularly those prioritized populations with HIV.
So let's think just a minute about some of the clinical implications of HIV and particularly the relationship to the respiratory virus conditions, not only COVID, but influenza and RSV. And where do we stand in terms of treatment and education around that relationship between HIV and those respiratory conditions?
It's a great point, Dr. Morgan. And so where do we stand? That is something that we're assessing now, right? So because of our close alignment with Morehouse Healthcare and having 4 clinics in the Atlanta metropolitan area, and then we have locations and physicians that are in some rural spaces in Georgia, we are collecting data currently to say, hey, where do we need to have more education? Again, you're talking about some respiratory elements. Where do we need to have, I talk about not just being siloed respiratory, along with cancer, along with diabetes care, along with heart health and conditions. So we are, collecting data and feedback from clinical providers to highlight, what do you know about HIV? What should we know? That you're receiving questions in terms of from those who are being impacted from HIV, from those who are being impacted from respiratory ailments, from those being impacted from cancer and diabetes and any other autoimmune deficiencies. So we're collecting that data to find out, hey, and that's something, again, that has not been done, Dr. Morgan. We're saying, hey, how do we make sure that we're very holistic in this? And we're starting with family practitioners, family care, and their PCPs. And so that's the first start. But we will like to go into other specialties as we go in to maybe talk to orthopedic surgeons, right? To talk with OBGYNs, definitely as we talk about the focus on Black women. That's a natural setting. We're talking with cardiologists as well to make sure we're getting that perspective. Again, it would be great to also connect with pulmonologists to say, hey, what are you encountering? If you have encountered those who've been diagnosed with HIV or those prioritized populations, what would you like an educational toolkit to look like, right? And so we know that there's always a need for more education. And again, not just for the community members at large, but for clinicians, particularly those who have shifted. We know that stigma exists in clinical spaces. We know, the training that clinicians get. So we know that we need to embed it in curriculum for those that are coming out or for training modules that we have in our program with our initiative. We've created training modules for clinicians. We're creating training modules for policymakers as well. We're creating training modules for community advocates, how to speak with policymakers, how to connect with their local clinicians if they're in, Albany, Georgia, where do they need to go? And so we're making sure that we're connecting the dots. And so, although we want to make sure that we include respiratory elements and conditions, but making sure we're including all those particular elements and conditions that are impacting, though disparately impacting Black community throughout the South. And so we want to make sure that we bring in all specialties and particularly all conditions. So the next round in education, hopefully, will have some more information from clinicians that are focusing and highlighting in those respiratory elements in terms of treatments, but also with HIV.
Now, in talking about educating providers, physicians, nurses, therapists, health navigators, and the like, at the 30,000-foot level, what is the Institute doing to influence leadership so that communities are being affected by the collaborative efforts, shall we say, whether it be a think tank, whether it be trying to visualize what actually is going on and make a change in that regard. And the reason that I'm asking that question gets back to the original goal and mission of the Satcher Health Leadership Institute, which is to prepare physicians and other scientists to be leaders, to be innovators, to be problem solvers. My concern is that we are very involved in the treatment side and sort of the reaction side, and we take the statistics and we're trying to deal with the statistics and we're trying to do all these things, which is admirable.
Right.
But I just wonder what kinds of things are we doing on a macro level to have more solid alignment. So there's not just one company or two companies, but multiple companies, that this is a major public health problem for the country and certainly for the Southeast.
Right.
And in lieu of the fact that so many people, educated African Americans, as well as, college educated African Americans, as well as others, are moving to the Southeast, a portion of the United States. Is the Institute involved in any of these macro discussions and strategies?
Of course. So as I talk about, and I'll highlight a few activities that we...
Because I know we only have a little bit of time here.
Yeah, that's fine.
But I'd like to add that, as well.
Yes.
To distinguish what the capabilities are of the Satcher Health Leadership Institute, compared to just the community health department, or the urban league, or somebody like that.
Right.
There's a difference, as I see it.
Yes. And aligning all of those institutions and those particular organizations is key. And that is what we do at Satcher Health Leadership Institute. We're not just operating in our silos, as we know. So we're bringing in Urban League. We brought in community-based organizations, community health workers. But particularly as you talk about the macro level, Dr. Morgan, is that we've created educational resources and educational platforms, particularly to focus and to that targeted audience of policymakers. It's very key that we educate policy, right? We're talking about as we dismantle established policies, historically established policies, and aligning ourselves with those policymakers, particularly we're talking about in a political climate that is very tension-ridden at times. We have to understand where we are in the South, historically, what's being said, what needs to be the focus. So we have key advocates that we've aligned ourselves, that within the Satcher Health Leadership Institute, federally, right? We know that we have friends in Congressional Black Caucus, as well as the Tri-Caucus, as well, that, reach out to us, and we're reaching up to them to make sure they understand the importance of what we're doing throughout this initiative and throughout the Institute. But also in the state of Georgia, we have renegades in the state legislature that are there on the front line advocating, preparing legislation, and we're just informing them what's happening on the micro level, what's happening in our communities, the cases that are there, the disproportionate outcomes that are being impacted. So we are, again, aligning ourselves in terms of informing, training, and educating policymakers who want to know, well, what's occurring? What's happening? What do I need to know? And they, in turn, educate their colleagues and fellow policymakers who are in these spaces. And they go again and advocate for more funding for researchers, more funding for public health departments, more funding for hospitals that are being closed in these communities where services need to be uplifted. But hospitals and clinics are being closed. So they have to understand the dire need, the absence of services. So again, we know at that macro level, it's a necessity to have that. That's why the Satcher Health Leadership Institute was created. That's why, again, we're naturally aligning ourselves with civic organizations as well, with leaders, and not just, we talk about the mayor's office that has an HIV commission there. Right? We're aligning ourselves with other local entities and also policymakers that understand, hey, we need to really be involved because my constituents, my voters are in this space, and I see that they're being detrimentally impacted. So we are naturally that force, and we have training programs for policymakers, right, to be there. We have asset mapping and data stories that are visualizing that impact in urban and rural settings. We have data mapping that is going to talk via data and visualization to say there's some inequity you see here. And when policymakers go to our data mapping platform, they see, oh my goodness, we really need to do something. This is impacting my constituents from that level, right? So we have the top-down level. And then, of course, we talk about community advocates from the bottom level, as we could speak, those in the field, community advocates and community advocates, those who are advocating and promoting, whether they be in spaces that are advocating for Black men, gay Black men wellness, whether they're advocating for Black sexuality and the promotion of that in Black women. What do we need to do? And aligning ourselves in Black maternal health, right? Those are spaces that we know that we need to fill in the gaps that are there with data, but also the visualization that's there. Because we also, again, we're connected and being funded we talk about through pharmaceutical companies. And so when we do some of our initial assessment and individuals are talking about, hey, there's some treatment out there for those diagnosed with HIV, I need to see myself when I see these commercials there. And there's a solution to prevent HIV. Oh, what's that called? Oh, PrEP. And so we need to continue that messaging and the storytelling when we talk about the misconception of PrEP just being a gay male medication. When women come in and we ask, hey, OBs, GYNs are asking, hey, I think, opportunity for you to get on PrEP. And Black women are saying, no, that's not me. I don't need that. That's a gay medication. So there's a disconnect there. So we're also informing pharmaceutical companies and those clinical providers to say, hey, what you've learned is not what is really there. Please advocate this and normalize this in your standard care of practice to make sure everyone who's having sexual activity, engaging in that, can be exposed to HIV, to a sexually transmitted infection. And so we're creating and aligning ourselves with other pharmaceutical companies. We're going into clinical grand rounds, Dr. Morgan, starting in January. Clinical grand rounds each month to educate those practitioners on what's happening in this HIV space. January, February, March, we're on the calendars now. That's a key step into what's happening and what we're doing in terms of this initiative. We might want to make sure and ensure that we're providing a robust educational program along with what's happening in social media. We have influencers that are there talking about what we're doing just today. Again, what's happening, what's going on, and making sure we normalize this, particularly as we know those younger generations are also being diagnosed earlier, right? Under 18. And so we need to make sure that we're going into these spaces where it's not so much talked about. It is different, Dr. Morgan. And now we need to make sure that we're here to make that difference and to make sure we're in those spaces that were not traditionally and have not traditionally been discussed in these spaces.
Well, I know that you have to run today, Dr. Standifer, and I really appreciate the comprehensive discussion that you provided for us today around HIV. My last question was going to be, what has been the impact of the Satcher Health Leadership Institute on HIV and healthcare? But I think each of your answers has addressed that, so we needn't discuss that. I would say that we have an opportunity to have further discussion around data and how we are gathering data, analyzing data, particularly in terms of, population movement and also community composition. I think those are important points. And I think to expand upon the relationships between the historically Black medical schools, where it's not so difficult to have a unified approach for certain advocacy purposes. And that's a role that the Cobb Institute has been involved in as well, as you know, but we haven't smoothed this out yet.
Okay.
So I think that strategy needs to be addressed. And finally, I think the continued focus on preparing leaders.
Yes.
And I'm an orthopedic surgeon, as you know. I've spent the last 20 years in infectious disease and health policy, which has nothing to do with fixing a hip. And so I've had to learn on the fly. And I learned that from Dr. Satcher.
Yes.
That when he was the Surgeon General, he had to teach himself about what the challenges were.
Yes.
And I don't caution, but I encourage the Satcher Health Leadership Institute to not stray too far away from that initial mission, because there are a lot of people that can make a difference in terms of providing local health care in the community.
Of course.
But there are not a lot of people, there's not a lot of expertise. There's only one Morehouse. There's only one Meharry. And we have a role to train our leaders to be influential. And you can't be influential if you're not knowledgeable about content, but also strategy. So those are things that hopefully we can address in the future. And we invite you as well to be a part of our webinar program that we now have on a monthly basis with blackdoctor.org. Certainly we can take part of this discussion and make it a very, very impactful discussion aimed, again, toward providers about what their role can be. So if you have any concluding thoughts, please share them with us. But I know you've got to run, but that's the great thing about podcasts. They just go on and on.
Yeah. Again, just echoing what you stated, using the resources, of course, my training and the opportunity to mentor. That is what I am. I'm a trainee of Dr. Satcher and Dr. Bill Jenkins from years ago in public health realm in terms of education and dedicating my career to community-based efforts aligned with policy initiatives. And that is what we do at Satcher Health Leadership Institute. As we talk about bringing in that knowledge from the medical paradigm and public health, integrating it throughout the community. We've created community health leadership programs, but also the training and the opportunities to do that within a clinical setting is very key. As I talk about normalizing the conversation of sexual health, whether it be STIs, whether it be HIV and AIDS, we need to ensure that it's academic. We know that that's very important. But we also, again, include those who are not in these academic settings. So educating our family members, informing school settings and leaders, churches, barbershops, beauty salons, social media influencers. Very key now. So we know our educational forums have changed. And now we have to really direct messaging to those who are really influencing, particularly the younger generation. And so while we're talking and highlighting what we're doing in these academic settings, let us not forget those that could be educators, amplifiers, activists in the natural community setting. And that's what we're continuing to do, to normalize these discussions in these natural spaces. That's what we've created. We're funding programs to really do a tiered educational and informational, programming that's occurring, but also understanding that anyone can have the empowered actions to change their lives. And so that is what we want to do. And we try to bring it together through our comprehensive programming, but want to ensure that it's sustainable beyond what we do. So embedding it in the curriculum for future clinicians is very key, but also understanding that highlighting the protection, empowering, and informing a young lady, a young man, that they can change their life by protecting themselves and informing them about how to be healthy. And improving self-esteem is very key. And that's what we try to do in our institute. I thank you both so much.
Thank you. Thank you for joining us today. And we look forward to future conversations.